From the heart of the NYU Langone Medical Center, this is Healthy Aging with Dr. Michael Perskin.
To start with, I'm really excited to talk about age-related eye disease with Dr. Bruce Rosenthal. He's an MD, and he's chief of the Low Vision Services at the Lighthouse Guild, an organization based in New York City that provides services for the blind and visually impaired. He's adjunct professor of ophthalmology at Mount Sinai, and he's a low vision diplomate. I always have trouble with that one, Dr. Rosenthal, of the American Academy of Optometry. So that's sort of a separate credential. And Dr. Rosenthal, Bruce, welcome to the Healthy Aging Show, and thank you for taking time to come.
Thank you for having me here.
Yeah, so I'm familiar with the Lighthouse Guild, and you guys do excellent work with folks. And there are similar organizations. Is Lighthouse Guild national, or is it in New York City based?
Only New York City. Yeah. We're a very large organization, which was Lighthouse International and Jewish Guild for the Blind, that merged 5.5 years ago.
Right. And so you guys maybe talk a little bit about the organization and what your goals are.
Well, our organization is one of the largest who take care of visually impaired, which we'll talk about, as well as totally blind individuals. And we get them services so that we can actually enhance their quality of life. And I think that's what most people want. Whether they're young or whether they're old, they want to continue doing what they've done in life. And that's what we try to do.
Yeah, so that's really important. And when I talk about a topic like this, right, so as a geriatrician, that's my background, right? I happen to know that visual disability is really actually the most common type of disability that we see in this country. I believe that's true.
Well, perhaps that's because people are living longer and longer, and it's increasing more and more.
Yeah, but because it's not when you see someone as an example in a wheelchair, it's pretty obvious that they have mobility impairment. Visual impairment, if someone is walking with a service dog or a cane, and maybe you'll tell me what that long cane is called that people who are blind use to help navigate.
It's actually a long cane.
It's called a long cane. Fantastic.
But you just said something very interesting, because a lot of visually impaired, and since we're talking about an older population, a lot of those individuals absolutely don't look like they have any type of visual problem. Yes. So they'll ask somebody for directions, or at the supermarket, and somebody said, well, why don't you put on your glasses? And basically, they're not going to share that they have a visual impairment, but they do look perfectly normal.
Yeah, and or at least not visually impaired. So that's the challenge. So maybe we should start with some definitions of what low vision is and how you would define it versus blindness, legal blindness, those kind of definitions.
Well, I think if we take what's normal, anybody who is usually better than 20/40, 20/30, 20/20, that would be considered in the normal range.
Corrected if you need glasses.
Corrected. Visual impairment usually is taken as 20/40 or less in the better eye. Why is that important? Well, if you want to drive, for example, in New York State, right on the driver's form, all it says on it is the vision better than 20/40 in the better eye? It doesn't matter if the other eye is blind. So it really becomes something important for us in terms of determining who's eligible for driving in New York State. New Jersey, by the way, is 20/50. So the states vary by licensure. As we go up the ladder, though, the greater the deficit, the more difficult it is to do what you want to do. Reading, if you're working, doing your work. As the visual impairment progresses, then we run into additional problems such as traveling independently. Finally, we get up to a definition of what is legal blindness in New York, New Jersey, Connecticut, and the nation. The United States has a different definition than the international world definition. It's 20/200. It's 10 times less than 20/20 in the better eye. So there's a two-part definition. One takes into account visual acuity, your eye chart vision. The second takes into account your visual field. Now, what does that mean? If your listeners take both arms and move them totally off to the side on each direction, you have a visual field of 180 degrees, half of a circle. That's what our normal vision is. And when we look at people in sports, somebody like Bill Bradley, who became a senator, was a great basketball player, they said, because his visual field was 190 degrees.
Wow.
So then we start to look at, well, what does visual field mean to people when it becomes decreased? Well, legal blindness is a visual field of 20 degrees or less in the widest meridian. So we're not using visual acuity as that definition. We're now looking at what's happening to their visual field. If somebody has a visual field that's decreased, they may run into a third problem, which most listeners have never heard about, and that's contrast. How black does something have to be before it's recognized? And I went off with a colleague and to an international low vision meeting held in Spain, and we gave a third definition that included visual impairment, visual acuity, visual field, and contrast sensitivity. So a lot of people as they get older say, you know, I'm having a problem reading the print, but it's getting too light for me. So it's a big issue and it's a big topic on why that's happening.
Okay, so those are the definitions, and so low vision is, from your point of view, and those of your colleagues in the field, is more about how it's defined legally, in a sense.
Well, more about irreversibility, meaning that once I get up to a certain level and I put on regular glasses and it doesn't correct to normal, what's going on? What do I have to use? Why isn't it normal? So there are obviously some types of changes in the visual system that are taking place. Basically, I'm going to use the term age 40 and on.
Sure. All right. Well, we are speaking with Dr. Bruce Rosenthal. He's Chief of Low Vision Services at the Lighthouse Guild. And we are taking your calls and emails here on the Healthy Aging Show on this topic. We're going to talk a little bit about what's available to help folks. But we'd love to hear from you. If you have solutions or questions about low vision or blindness, we'd love to take them. You may email us, docs@SiriusXM.com, or call 877-NYU-DOCS. That's 877-698-3627 here on the Healthy Aging Show, and I'm Dr. Michael Perskin. So what causes all this? So you actually sort of alluded to it. So the decreased visual field is glaucoma, right? That's sort of the most common disease that's associated with it.
Absolutely.
Right. So that people should be screened for glaucoma?
Well, I want to talk a little about glaucoma because I'd like to talk about two things that people don't realize. When they go in and get glasses because, well, I need reading glasses about age 40 to 45, they go in, they pick off a rack, a +2, a +150. That's where I see we're running into problems with patients that I see. Older patients can save money, but the problem with glaucoma, it doesn't have any pain often.
Yes.
You absolutely don't know what happens. So how do I know when a patient really has a serious problem with it? The first thing they tell me is, all of a sudden I bumped into an object that I didn't see. I knew I was going into the room, but I didn't know that object existed. So all of a sudden they have an irreversible loss in their visual field that could have been corrected by routine checks.
Yes.
So what's the most important thing with somebody with glaucoma? I go into, do you have any risk factors, meaning do you have a family history of anybody who's had that problem? In fact, the last person I saw this morning said to me, well, my mother has glaucoma, and my sister and my other sister.
Yeah, that's pretty strong.
And so that person should have been taking periodic examinations at least every year minimum.
Yeah. Yeah, I strongly, as a primary care physician, I encourage my patients over 50 to go every year, with or without a family history, but certainly, or at least get screened for glaucoma. Because as I tell the patients, I can't do that screen as someone who does a lot of preventive medicine. I wasn't trained in how to do it, and we don't do it in the primary care office. Maybe in some future we'll have some way to do that, but right now we're not doing that.
But there are a couple of things going on in glaucoma. One, it's elevated eye pressure,
yes,
which most people are aware of, that they have to take my eye pressure. It's like blood pressure falls between a certain range, 10 to 20 millimeters of mercury, theoretically is normal. But in the early part of this century, they found out that the front part of the eye the cornea played a role in determining who's normal and who's not normal. We would take eye readings with a device called a tonometer, press on the cornea first,
Right.
and the reading might be deceptive because I'd get a low reading, but there was a problem because the cornea was a certain thickness that gave me a low reading, but it was really a higher reading. Conversely, I could get a higher reading, but it's really in the normal range. So they came up with a chart on determining what's normal if you have this thickness cornea. So it's not just a matter of eye pressure nowadays, it's a matter of measuring the thickness.
So who does that when they just put the
Well,
little blue
generally,
light on?
any eye doctor, ophthalmologist or optometrist, when somebody's sitting in your chair, they're a patient.
Yeah.
And you have to make sure that you're going to check for that, especially starting at, let's say, age 40 and a patient doesn't have any history, as you're saying. I'm going backward 10 years because glaucoma usually begins in the early 40s, again, without any kind of warning sign.
So those are my patients that tell me they have increased intraocular pressure.
Correct.
They've been told this based on the thickness of their cornea and the measurements and things.
Correct.
Got it. All right. So we are speaking with Dr. Bruce Rosenthal. We're taking your calls and emails. We're talking about low vision and eye disease as we get older. This is Dr. Michael Perskin on the Healthy Aging Show. You can send us an email, docs@SiriusXM.com, or you may call 877-NYU-DOCS. That's 877-698-3627. Now I've got an email from Kiki in Rhode Island who writes, how do I know if I have an age-related eye condition? I'm a 55-year-old female and I now have problems with blurred vision. I also get headaches when I don't wear my glasses. What does this mean and should I be concerned?
I think that anybody who comes in with a complaint of blurred vision who's 55 really should have been looked at earlier. There can be a whole host of what might be causing it. Generally, I'm going to introduce something we haven't talked about, but cataracts usually begin a little later than the 50s unless there are other pre-existing conditions such as diabetes in which cataract can run or some kind of trauma that's taken place. But in this instance, the first thing we're going to look for is, will corrective lenses take care of that?
Sure.
But if you're going to look at corrective lenses, then you're also going to look at the eye. And again, getting back to taking the eye pressure and taking a dilated exam, meaning you're going to look in the back of the eye at the retina, which is a very important structure because it's the only structure we basically could look inside and see, wow, there's bleeding that's taking place. There might be a tumor that's taking place. And at age 55, blurring has a cause. It might be a simple cause, but it might be something more serious. Again, it might be glaucoma. It might be early changes from macular degeneration.
Sure. That makes sense. And certainly, even if she had no symptoms at 55, you and I would both recommend her to be screened.
More than a screening. I'm going to recommend a complete
A
examination.
complete exam. So my apologies.
Okay.
Right. And so, well, but if the patient has no symptoms, then a complete exam, to my way of thinking, is a screening, not to be argumentative. Right?
Okay.
You're screening not just for glaucoma, I think, but for macular disease and other stuff.
Absolutely.
So, right, so the other age-related conditions are just those, right? Is cataracts you mentioned.
Cataracts, macular degeneration, glaucoma, and then we get into some other conditions. Stroke.
Sure.
Stroke is going to cause a visual field loss in most cases. I saw a patient last week who had an aneurysm, which resulted in a stroke. I mean, he fell and lost his visual field. I mean, we're talking about very serious things.
Sure.
So I think when somebody comes into the office, as you're doing a complete history about, well, what's your diet, what's going on with other health issues.
Yes.
And I think they all come into play at that point in time.
Great. All right, well, let's go to the phones. We got Madeline calling from here in New York. Madeline, welcome to the program.
Hi, good afternoon.
Okay.
So my mom had neovascular glaucoma, and she lost sight in one eye, and they were trying to preserve it in the other eye. She went to a retina specialist where she would have to have like this laser treatment and also injections in her eye because I heard this condition could be very painful. Anyway, she passed away last June, but my question is actually, am I susceptible to also getting this condition? And does it have anything to do with blood pressure?
I think that's a great question. And I think nowadays when we look at anyone's history, one, you have a risk factor of somebody in the family who had a very serious type of age-related macular degeneration. You should have a eye examination minimum every year, as we've been discussing. You should have an examination, again, that's a dilated fundus exam, meaning they're looking at your retina. They're looking for signs. Will you get it? Often it skips generations, but I think we have certain groups, especially in New York City, that have higher incidence, meaning we have a lot more age-related macular degeneration in specific groups. I can point out different parts of the world. For example, Ireland, Northern Europe, Eastern Europe, Italy all have pockets of macular degeneration. Will you get it? The answer is we can't tell unless somebody looks into your eye. I think blood pressure, I think health issues play an important role in developing macular degeneration if it's not under control. I also think diet and other issues also play a big role, such as smoking. And I have to say that I wrote a book a long time ago about age-related macular degeneration, and at that point, about over 15 years ago, smoking was implicated as 2 to 6 to 8 times more implicating macular degeneration that you would develop it than anything else. So smoking is the big parameter for a lot of diseases, but especially in developing age-related macular degeneration.
Okay. Well, that's good. I quit 18 years ago, so that's good.
All right, Madeline. Thanks so much for your call and great question. Next, I think we have Sue, who's calling from Illinois. Hey, Sue.
Hi. Can you tell me those glasses that are like at the dollar stores, the $2.50 glasses for the that have the different numbers? Are those bad for you, or are those should I be doing glasses like that with the eye doctor?
Well, I mentioned it briefly before. I have great objection to over-the-counter glasses. One, it's not your prescription in most instances. It's rare that it'll be exactly your prescription for the right and the left eye. The glasses are made for a general person, meaning the lenses are set at a specific distance in the right and left eye, so it's equal for everybody in the United States. You might get headaches. But I think the most important thing, when you pick them up off the rack, you're not getting tested for what we're talking about right now, age-related conditions that can literally lead to blindness.
Yeah, Sue, I'll restate that a little bit. So, like a lot of things that are over-the-counter in terms of availability, it skips the screening step, but the reason why there's a screening step is because these diseases can have complications resulting in disability or in some screens death. So just because you can get it doesn't mean you should do it. And I guess I from my own point of view, I just have when I recommend the patient to have a complete eye exam, which is more or less every other year in their 40s and then once a year after 50. That's my own recommendation to my patients. So if someone is 40 and they do fine with the store-bought reading glasses, I'll say that's fine, but just go to your eye doctor. For a younger person, it becomes a little easier. Particularly when people tell me they don't work, they really need to go get seen for one reason or the other. And I can give you an example because it's personal for me. So I could never use those. I have a fair amount of astigmatism. So they just simply won't work for me. And I've been going to an eye doctor nearly every year since I was 40.
But I think you're common in the general population where the component to your eyeglass prescription is called a sphere and a cylinder. We're correcting for, say, nearsightedness, farsightedness, but also for astigmatism, which would cause a letter to be not as black and all. For example, the H might be dark going across, but it would be light, the two legs coming down. So it would make reading much more difficult.
Yeah, and it's tricky to get right.
Absolutely.
Yeah, that's been my own experience. So, Sue, thanks for calling. Next, we've got Nicole, who's calling from California. Hey, Nicole.
Hi. Thanks for taking my call.
Sure.
I have watery eyes every morning. I have to use one of those, what is it called? The microwavable hot, I don't know, the cloth that I got it from Walgreens. And then I use it, put it on my eyes, as my doctor said, and I have dry eye drops, and sometimes I take antihistamine for allergies. 50% better after I scrub my eyes when my doctor prescribed it. But still, I have 50% tears on my eyes every day, and it causes so much problem for me. And my eyes are swelling like I'm an old lady.
Well, I personally don't think when your eyes are swelling and tearing like that it's a normal problem that you should just let go. I mean, sometimes for some of the listeners, if you get up and your eyes are a little gritty, there's generic things called lid scrubs, and you can wipe a pad with one eye and then the other eye to clear it up. But sometimes what happens is there's a little canal in which the tears drain through that canal. And I would recommend that you go see a doctor about this drainage problem, perhaps, and strategies that may make it less tearing, as well as the other problems you're describing about the puffiness.
I have an appointment on October the 10th to get rid of the extra skin, the upper lid, and then get rid of the packets under my eyes. It's a surgery that is going to be happening on October. So, and then my doctor said it's okay if you do the surgery to just get rid of the extra skin and then the puffiness. But the tears, I'm afraid if I even do the surgery, the puffiness and then the tears causes more puffiness, and then it gets to where I was before.
I think the two of us sitting here would say it's something you really have to discuss with your surgeon. That's the person who's managing your situation right now.
Yeah, and Nicole, one thing I'll say is sometimes when you have trepidation, it's because the doctor may not have listened to the entire story, or he's sounds like you have more than one thing, so you might consider getting a second opinion. Based on what you've said so far, there are specialists called oculoplastic specialists. If you're worried about the puffiness and then how the one thing is going to affect the other, you really want to think carefully, because I will say that for some eye surgeries, very high rates of satisfaction. Cataracts come to mind immediately. People are super happy, almost immediately in general. Very low rate of problems. But with things like Nicole's describing, there's a higher rate of people kind of were going in for something different.
I think one of the things that you're talking about is really a specialization in every area.
Yes.
You have your cataract doctor and the oculoplastics doctor, your glaucoma doctor. So it depends on what you're being treated for. There's usually a specialist that's doing that, especially if you live in California.
Yeah, but I guess my point, Nicole, is that there are different approaches, and there could be completely people who have data and they have a position. And it's tough sometimes, because I get the patients coming to me and they've heard there's not 100% agreement, and for good reason sometimes, and often there's no answer, and we don't know what's going to happen. So my experience to tell my patients has been, you got to go in, pardon the pun, with your eyes wide open. So you're better off doing the due diligence, unless someone's telling you this is an emergency, because then if you have even a simple little thing that's not that big of a deal, it's going to be really gnawing at you post-operatively if there's any little blip or bump in the road. So I would strongly advise, and I would be totally upfront with your eye surgeon about it, because he or she will be happy that you're doing that. They want you to do their due diligence. They don't want to have an unhappy person with their vision after surgery. No one wants that. Good luck, and thanks for calling. Next, I'm going to go with Bob, calling from Connecticut. Bob, welcome to the Healthy Aging Show.
Hi. So my question concerns blood pressure and glaucoma.
Sure.
I'm treated for both. My blood pressure is well controlled, about 120/80. My cardiologist would like to get my blood pressure lower, but my glaucoma specialist says no. He says that'll be bad for my eyes because there's something called OPP. and I don't know how to mediate those two sort of competing concerns.
Again, I think what both of us would, at least I would say, is I think those two doctors have to speak to each other about what's going on.
Yeah, Bob, I agree with Dr. Rosenthal, but I'll add something. You have to decide what risk is a priority for you. So this would be something called shared decision making, and the doctor should duke it out, so to speak, but you need to, it may be that you have to prioritize what's more important to you. And the ways you can do that, so as an example, if you have a terrible family history, I don't know, you haven't said what your family history is of stroke and heart attacks. If you have a kind of bad family history of that, you might prioritize prevention of stroke and heart attacks over the visual problems. If you have a family history of visual problems and not any of cardiovascular disease, you might prioritize that more. So you have to help the doctors and kind of figure out what is important to you. And a lot of times, that's a whole patient approach, because taken separately, you're getting conflicting advice, which is the problem. So I strongly recommend you figuring out for yourself what's important, and that may entail thinking about your family history or thinking hard, and these are tough conversations about what you value more, how what fears you have, what concerns you have about your own medical future. And that'll help the doctors kind of come to an agreement about what they're going to do. And hopefully they can solve both problems, and that would be the best solution. So hopefully that helps, Bob, and thanks for calling. Next from Ohio, let's speak to Karen. Karen, welcome to the Healthy Aging Show.
Hi, thanks for taking my call.
Sure.
I have a daughter who is 28, going to be 28,
Mm-hmm.
and she was diagnosed with ocular rosacea. She had gone to several different ophthalmologists and or doctor ophthalmology, and she was diagnosed. And anyway, my question is, she just had her first, it's called the intense pulse light therapy, and she lives in Raleigh, North Carolina, and she said it would be a total of 4 treatments, a couple weeks apart. I don't really know much about that, and I just wondering what your thoughts were on that.
That's a condition that I'm not dealing with in my aging population at all.
Yeah, so Karen, that sounds like a super specialized thing. So you might want to have her, if she's got some concerns, I don't know if there's an eye center there or what the nearest place would be. So again, sometimes a second opinion from a national expert center for unusual things. I've not even, I don't think I've had a case of that in 30 years of clinical practice taking care of adults. So it's clearly pretty unusual. So it's best to go to people who have a lot of experience, and with the availability of all that information online now, and every medical center and eye center has got their bona fides up on their internet. It's pretty simple to find some, and even now it's even getting more amazing because people are doing telemedicine, so you might soon or even now not have to travel, which will be amazing. We do some telemedicine with our ophthalmologist here at NYU in the emergency room. So Karen, sorry not to give you a specific answer, but hopefully that helps you and your daughter. For our listeners, we've been speaking with Dr. Bruce Rosenthal, Chief of the Low Vision Services at the Lighthouse Guild, and author, and on the faculty at Mount Sinai Hospital. Dr. Rosenthal, thank you so much for taking your time.
I appreciate being able to come here.
All right.